Welcome back to the Pager Podcast. In this episode, we were lucky enough to be joined by Professor Linda Bauld for a discussion that takes us into the core challenges faced in public health. Professor Bauld studied political science at the University of Toronto before gaining her PhD in social policy at the University of Edinburgh. Since then, she has worked in various areas of public health, serving as the UK's advisor on tobacco control and Cancer Research UK's prevention champion. She now works as the Bruce and John Usher Professor of Public Health at the University of Edinburgh, where her interests include tobacco control, reducing obesity rates, and cancer prevention. We start off with touching on both successes and ongoing challenges in reducing smoking rates, part of a field that Linda has really been a world leader in. This leads on to a more general discussion of what actually makes public health interventions work, and indeed the challenges of working out whether a policy has actually been a success in the first place. We move on to clashes that can occur between the promoters of public health and vested interests in the food, alcohol and tobacco industries. We talk about political and economic pressures on public health, as well as some of the ethical debates surrounding personal freedoms and balancing short and long-term consequences of such interventions. COVID-19 does make an appearance, and Linda draws parallels between the ongoing pandemic and management of already established public health challenges. So one episode could never really do justice to all of this, but we hope you enjoy the discussion. As ever, don't forget to subscribe to the podcast and do share it if you've enjoyed it. Linda, it's a pleasure to have you with me today. I've been really interested in your work at the University of Edinburgh. Could you just introduce kind of broadly what you're doing up there?
Thanks very much. So Linda Bauld, I'm a Professor of Public Health in the College of Medicine at the University of Edinburgh. I'm a behavioural scientist. Most of my work traditionally has been on the prevention of chronic disease, non-communicable diseases, particularly cancer. Obviously at the moment, like everybody in public health, I'm primarily working on the COVID response and science communication around that. But I've done a lot of work on inequalities, nicotine and tobacco research, alcohol, and more recently I've done some work on overweight and obesity and the diet policy.
Focusing in there on lots of your work in smoking cessation and anti-smoking campaigns, what have you learned from this about what kind of works and doesn't seem to work in public health?
So what works really in terms of behaviour change or trying to deal with preventable risk factors like smoking is a multifaceted approach, a comprehensive approach. So you have to think about how you try and move forward with the relationship between people's environment that they live in and also the choices that they make, their behaviour. So the environment has to be supportive for behaviour change, and people need to feel that they have the capacity to change behaviour. And that might be not starting to smoke in the first place, but it also might be about smoking cessation, which is something I've done a lot of. So a comprehensive approach. And in terms of the environment, we often talk about the 4 Ps, which are price, product, place, and promotion. And you need to take action to regulate all of those when you have a product like tobacco, which is particularly harmful and not beneficial for people's health.
In the pandemic, we've seen a lot of criticism of the action of the public saying, oh, well, such and such an intervention would have worked, but for poor adherence or people not following us or flouting the rules. Do you think that more broadly, this is a kind of a useful narrative to have, that things would have worked if only people had followed them?
I think it's actually a very unhelpful narrative. I mean, there is a grain of truth in it in relation to COVID and around self-isolation or not following physical distancing or not wearing face coverings. But the problem is that the public will only comply, or people will only comply with public health guidance and public health policies if they feel there's something in it for them, if there's a reason for them to engage. So that you need to actually be supportive rather than punitive. The only reason for things like penalties is to send a very strong message that something is unacceptable. I mean, there were penalties for around the smoking ban, for example, requiring business owners to have signage and to make sure that people were not able to smoke in their premise like a pub or a restaurant. But I think blaming is really harmful. And in the COVID context, we've seen different kinds of blame. We've seen young people be blamed in particular for not following guidance. So we've seen people be blamed for requesting a test and taking up too much of testing when previously for months they've been told to go and get a test if they have symptoms. So I think it is really unhelpful. And certainly in my own work in behaviour change, you can see that a supportive approach, a positive messaging actually has more of an impact than a punitive approach.
So what do you mean by positive messaging in this case? Could you give any examples of that?
So if we just talk about mass media, for example, you need to think about conveying messages in public health communication campaigns that give people a reason to change their behaviour. So, for example, secondhand smoke is a really good example there. We've often used images of children. Most people will remember quite a powerful advert with a baby in a car seat and seeing the smoke circulating around its head. So really sending the message that to protect children, you need to make sure you're not smoking indoors. Alternatively, you can have fear-based messaging, which is just showing people, for example, a diseased lung or a damaged artery, a fatty artery, fatty veins, the impact potentially on cardiovascular health. But alongside that, you need to have a telephone number or a website where people can access free support if they want to quit smoking. So you have to have positive messaging. And I think some of the mass media campaigns around tobacco are a good example of that, but also healthy eating, for example, which is quite current at the moment.
And we'll hopefully get on to some of the other areas that you're really interested in a little bit later in the podcast. But I wanted to touch a little bit on this fear-based messaging, which obviously in some cases can be really, really effective when we're talking about kind of horrific images on packets of cigarettes. And my question here is there a conflict between essentially what we're trying to achieve in public health, which is obviously to change someone's behaviour, and actually having a proportionate message to that individual? Because it's perhaps more effective to really scare people about things and exaggerate risks in order to get them to change their behaviour than to give a slightly more moderate view on it.
I think I understand what you're saying. I think it depends on the topic that you're trying to address. And I think the thing with combustible tobacco is it is so harmful to health. And also we know from research, not so much nowadays, but in the past, that people were not aware of the risks. So what you're trying to do, for example, showing images of diseased lungs, as I said, or even to do with a baby who needs to be in a neonatal unit because the mum smoked during pregnancy, is to raise awareness of the risks. And some of the fear-based messaging is really about that kind of education. But also seeing an image that's a little bit shocking is something which people pay attention to, not always repeatedly, because these images can wear out, as in people just ignore them. But when they're newer, that prompting attention can make or encourage people to think about something they regret or behavior that they want to change. So there is a place for that kind of messaging. But as I say, it's much more effective if it's combined with positive routes for support. To give you a practical example again from cigarettes, in Canada, and this is something we've been trying to argue should be introduced in the UK, in partnership with much larger health warnings or standardized packaging of tobacco, when a smoker opens the pack, inside there's a card which gives advice and support about quitting smoking, and again shows how you can access free support. So it's that combination which I think works particularly well.
There's a risk that certainly public health messaging can end up shunning the very people that it most wants to help and most wants to access, and actually shutting them out of the discussion around it.
I mean, stigma is quite damaging. Smokers have been stigmatized. There's absolutely no doubt about that. There's a bit of debate in the literature about whether stigma is actually helpful, because it means that people don't want to be seen to be engaging in a behavior that's stigmatized. I mean, actually smoking in pregnancy is a really good idea. Not a good idea at all. It's a really good example, because I've done a lot of work with pregnant women over the years, including interviewing pregnant smokers, and they will say things like, if I'm visibly pregnant, I wouldn't go and buy a pack of cigarettes in the city centre where I work, where I've got all these more affluent people who are non-smokers, but I don't feel so bad doing it in my more deprived neighbourhood where there are more smokers. And that suggests that smoking is stigmatised in one environment, particularly smoking in pregnancy, but not so much in the others. So, but I think my own experience over many, many years actually is that stigma is unhelpful. And I think we can see that in the pandemic as well. We, in the early days of the pandemic, when obviously most of the cases were in Southeast Asia, there was some really harmful examples of actually quite racist behaviour towards people of Southeast Asian appearance in the UK. And that's just incredibly damaging, and we need to avoid that kind of thing. And
touching on what you said earlier, a very, I think, striking statistic is that 10% of women still smoke during pregnancy. And obviously there are enormous, as you alluded to, enormous variations in those rates across the country, with quite low rates in affluent areas, for example, in London. This almost points to we've had decades of messaging about it, and the reduction in smoking rates in Britain has been a testament to the success of public health interventions. But we still certainly have a way to go in that case. What do you think you would like to see going forwards here?
Sure. Well, there's two issues there. There's still 7 million smokers in the UK. You're right, we have the second lowest rates of tobacco use in Europe, which is great, particularly as we have the highest rates of smoking in the world in the 1950s and 60s. But the problem is cigarettes are still available, and they're not an illegal product. People can still access them. And the vast majority of people, over 80%, start smoking before the age of 18 or 20. You know, this is not an adult choice, it's a childhood behavior, which then becomes an addiction. So I think what we need to do now, even though we have low smoking rates, is continue to apply comprehensive tobacco control. So the 4 Ps I talked about earlier, but also look for more innovative approaches. So in terms of smoking in pregnancy in particular, the reason why the rates are so much higher in deprived areas is because those women live very challenging lives, and smoking is something that they say helps them. They believe it relieves stress, and also it's more common that other people around them are smoking in those communities. So for those pregnant women, the most important thing we can do is give them support and help. So that's smoking cessation services, access to smoking treatment. And at the same time, at the population level across the country, we need to keep the price of tobacco high. And we've also talked about something which hasn't been implemented yet, which is using a polluter pays levy. So essentially putting a levy on the industry for the products that they produce, which are harmful to health, and then using that money to pay for services like services for those pregnant women. That's something else I think we could do in the UK. Other things we've talked about are kind of more experimental, like dissuasive cigarettes, which is, we have standardized packaging now, but we could actually put a health warning on the cigarette itself, or even use a muddy green color for cigarettes in the UK. That's sort of a more interesting idea. And then there's some wacky ideas like having a vocal health warning when you open the cigarette pack, so you hear some words. Things like that have been trialed. But my own view is that implementing comprehensive tobacco control, no advertising, high prices, no smoking in public places, and access to free smoking cessation services will continue to drive rates down. And then the final thing is, you know, people who are nicotine users, many of them want to continue using nicotine. And of course, we have other products now like vaping, electronic cigarettes, which are viable alternatives. And as the years have gone on, we now have very considerable evidence that they do help people stop smoking and that they're less harmful than tobacco. So although we don't want non-smokers to use them, giving smokers alternatives like vaping or stop smoking medicines is really an important way forward.
And indeed, it's an interesting question of how can we prove that actually promotion of e-cigarettes does not lead to uptake of smoking, for example, in the opposite direction, or uptake of other drugs, or acts as a gateway here?
So proving it is difficult because you're not going to have a randomized control trial where you randomize half people who never smoke to vape and the other half not to. Those are unethical studies usually because they involve young people. So what we have to rely is on observational evidence, of which we have a lot now. And what you can see is that in terms of vaping in young people, even in the years where e-cigarette advertising was permitted, keeping in mind most of it is banned now in the UK with the exception of outdoor advertising and some online advertising, rates of e-cigarette use in young people were actually pretty low, and they remain very low. There's quite a bit of experimentation with vaping, but regular use of e-cigarettes amongst young people is at less than 0.5%. And that really hasn't changed over the last 5 or 6 years. So though there are some prospective studies, follow-up studies, particularly from the US, that show that if somebody starts vaping, they are more likely to go on to try smoking or become a smoker. You can't disentangle those findings from the type of young people those are. They might be more risk-taking, they might be more susceptible to becoming dependent on nicotine, they might have more friends and family that smoke. So far, we haven't seen strong evidence that vaping is a gateway to smoking. And we also haven't seen strong evidence that loads and loads of young people who've never smoked are vaping. And we've had these products on the market since around 2010, 2011. So I'm pretty confident about that evidence, but I'm sure it will continue to grow.
And do you think that we could see a change in this were advertising for e-cigarettes to be allowed much more widely in the UK? Because there's this balance that if we restrict advertising of everything, then this, to some extent, stops a competitive edge that actually a much safer alternative could have over the much more dangerous alternative, which are cigarettes.
Yeah, I mean, that's a really interesting and it's actually an excellent question. The reason why e-cigarette marketing is largely banned is to protect young people. And if you look at other what we call harmful commodities, alcohol, where there's very little restrictions on marketing, obviously foods that are high in salt, sugar and fat, where there's an active debate about restricting some of that marketing. In fact, there's just been a consultation launched on banning all online marketing of junk food by the UK government, which will be really interesting to see if they can achieve that, because no other country has. So I think that's your question. If there was much more vaping advertising, would it probably contribute to more young people taking it up? My personal view would be yes, it would contribute. But on the other hand, it would probably encourage the third of smokers in the UK who've never tried vaping to try it. So it's quite a fine balance. I think we've probably got it about right, but I would like there to be more awareness amongst health professionals in particular. And I do train GPs myself. I'm involved in some workshops for GPs every year about vaping, and just to get them to have a little bit more confidence in talking to their patients who smoke about vaping as an alternative. They can't prescribe it, they're not medicines, but they can engage with patients on that.
I think it's easy to forget that actually if there's 7 million smokers, this is over 2 million people that we're talking about who haven't potentially tried a source of nicotine that's far safer and could be effective at preventing them from smoking.
Absolutely right, particularly given that most recent randomized controlled trials do suggest that vaping is superior to nicotine replacement therapy for smoking cessation in particular.
Taking a kind of a broader view on this, you talked a bit about advertising for junk food, and I'd like to take a step back and say, do you think that some of the successes that we've seen in reducing smoking uptake in the UK actually can be translated into other areas? We have an obesity epidemic in the UK currently, and the sort of things that we've learned and the tactics employed in public health are transferable there.
Yes, I think the vast majority of them are. And in fact, I've been involved in 2 pieces of work where we have tried to use a model of tobacco control, or at least similar to tobacco control, to apply to other areas. So I led the development of an independent alcohol strategy for the UK that was published in 2014 called Health First. We had an expert group that met over 2 years, and we used very similar, I talked about those 4 Ps, and the 5th P is people, so supporting people. We use the same kind, it is the same kind of thing. Remove the advertising, make the product more expensive, the most harmful types of products. Minimum unit pricing is aimed at doing that in Scotland. Make the product less available, which we haven't had much success on in alcohol, and also even adapt the product. So with alcohol, could we have lower alcohol products rather than higher strength products? So that exists, and it's the manifesto document for the Multi-Agency Alcohol Health Alliance. It's used to lobby political parties. And now I'm involved in an independent healthy weight strategy for the UK, led by the Obesity Health Alliance. And we've obviously had good developments at England level, in particular with a new plan published by Number 10 on obesity just recently during the COVID-19 crisis. We think in part because the Prime Minister himself developed COVID-19 and became very unwell and realized that his weight might have been a factor in that, because of course overweight and obesity is a significant risk factor for COVID-19 disease severity in particular. And so we're absolutely trying to apply lessons from tobacco control in that independent healthy weight strategy. And I think we will see things like really quite heavy restrictions on junk food marketing in future years in the UK. We'll see calorie labeling, for example, on menus and products, better health information on the products themselves. We've already got a sugar levy on sugary drinks. There's other price measures that can be put in place. And there are other things like banning multi-buy offers of junk food in supermarkets, and removing junk food from, for example, end of aisle, carousel displays, or near tills. So these are all things that we've sort of done with tobacco that are now under discussion for other commodities which are more complex to regulate, but can be harmful to health, such as alcohol and some unhealthy foods.
And indeed, I think also slightly more complex to actually determine the effect of the interventions that are being made, which I know is quite a keen interest of yours. How exactly do we go about doing this? Taking a public health intervention, for example, let's say adding a sugar levy. And in this case, determining that it actually leads to the endpoint that we are interested in, which is ultimately making a happier, healthier society, saving money for our health service as well. Because I think it seems like in smoking, actually, we have this quite clear kind of surrogate endpoint. If we can reduce the number of people smoking and reduce the amount that they're smoking, then that is seen as a win all around, even though there are these, obviously, caveats that people might be moving on to other potentially more harmful substances. But overall, we've got quite a key kind of goal in mind. But when we talk about, say, a sugar tax, there are lots of alternatives that people could, a sugar tax on fizzy drinks, for example, actually disentangling it from all the other changes in behaviour that could come with it could be quite tricky.
I mean, evaluating public health interventions generally is incredibly complex. And one of the things that I've encountered consistently in my career, because I've done a lot of collaboration with people from multiple disciplines, and I sit on a number of funding panels, including where you're looking at basic science and clinical research. And I think my colleagues in those fields, while they are very complex, are sometimes quite surprised by how difficult it is actually to evaluate a public health intervention. So what you need is multiple methods and also multiple outcomes. So just to use your example of the sugary drinks levy, you're right that when you assess smoking, tobacco control, you really got you've got three main outcomes. Does somebody prevent it from starting to smoke? Does somebody stop smoking? And also, is there harm reduction? So do they reduce the harm that they're exposed to? With something like sugary drinks levy, you're really thinking about diet. But you're also then thinking about your final outcome, which is overweight and obesity. So BMI or somebody's weight. So to assess that, and there is a very complex evaluation of the sugary drinks levy actually, which is still underway, you need to think about what are your short, medium, and longer term outcomes. So your short term outcomes might be that people are spending less money as a proportion of their food basket on sugary drinks, or that the price of drinks goes up as a result of the levy. And those two things have occurred. We already have evidence of that. So that's a short-term outcome. A medium-term outcome might be then that people's diets actually change, that sugary drinks constitute less of what they're consuming. And you can get that from surveys, qualitative research, etc., and including actually longitudinal surveys, some of the cohort studies that we have. So that can be assessed. Those are changes in diet. And then changes in your final outcome, the population's weight, people's weight, is actually quite difficult to attribute to the sugary drinks levy with confidence, because you're then saying that it's the levy that's done that and not all the other stuff that's happening in the environment. And I'm not sure that the evaluation that's underway is actually going to say much about that final endpoint. And that's why probably to try and address overweight and obesity in the UK, you're going to need lots of different interventions, and you're going to need research that shows there is a pathway, but it won't necessarily be able to say that a single intervention made the most difference.
And it almost seems to me that it's very easy to say, what if, oh, there's something that hasn't been taken account for. Do you think that actually it's just a case of reaching a threshold where we think actually this is highly plausible that this sugar levy is reducing the amount of sugar that people consume? We know that. And it's highly plausible that that is contributing towards the trend seen, or do we need more evidence there?
I think if I was an industry actor, if I was a company that made soft drinks, for example, I would be calling for really robust evidence of the kind you say that, by changing my product or making it more expensive, that will encourage people to lose weight or children not to become overweight, etc. Industry actors often ask for that type of evidence. It's really difficult to show, to prove. It's similar like, does junk food marketing encourage young people to eat more junk food? The industry continually debates whether the evidence we, the public health community, produce is good enough. I think it's good enough, but they would disagree with that. So you really do have to rely on those short and medium term outcomes. And then you have to essentially have faith and observe that what's happening in one country or what's happening here in relation to those outcomes will contribute to the longer term outcome. It's really quite difficult sometimes in what we call health improvement, non-communicable disease prevention, to definitively prove that something we've done has directly contributed to the outcome. Much easier in the time of COVID, I think. Infectious disease outcomes are sometimes more apparent and immediate.
Certainly, if you want to, there are obviously some difficulties when you've got quite low prevalence of COVID-19 in countries, but certainly the outcome that we're looking at, even if it's infection rate or mortality from COVID-19 is very immediately presentable rather than an obesity-related cancer a long way down the line.
Exactly. Yeah, spot on.
I'd say, just on what you said earlier, that actually I'd question why a junk food company is advertising on TV towards children, but saying that there's no evidence, or you haven't provided sufficient evidence that it's effective in the first place.
Oh, yes, totally. I mean, that's absolutely a really good thing, a really good point to make. Yeah, why would they spend millions of pounds on marketing their products, breakfast cereals, for example, if they didn't think that children were going to want to eat them?
This idea of vested interests, which is something that I think you have to grapple with a lot in public health, whether it's the tobacco industry, whether it's the food industry. How should we deal with evidence from those sectors? And do you think it's following the same pattern where we've seen major journals not accept research from the tobacco industry anymore because there's so much conflict here? Yeah,
it's very difficult. I mean, I have colleagues who do a lot of work directly in this area, vested interests, commercial determinants of health. In fact, I lead a consortium that's looking at those issues, research consortium. It is absolutely the case, using tobacco as an example, that the tobacco industry have a long history of trying to distort the science. And one of the tools they use to distort the science and create doubt is that they produce their own research, which has contradictory findings to what public health researchers who are not conflicted might produce. And then they publish that in journals. And that's the explanation for why a number of journals are not accepting, for example, the British Medical Journal's series of journals do not accept articles where somebody's had tobacco industry funding. And I think that's valid. And I think we might see that, and we have already seen it with some journals with alcohol, for example. We may see that much more widely because there's a fundamental mismatch between a company's responsibility to its stakeholders to increase profit, to sell more of its product, which may be a harmful product, with the objectives of public health. The two are not aligned at all. I would say, though, it is very complicated. It gets much more complicated when you think about food. So who is the industry? Is it a supermarket or is it just the producer of a product? And again, in relation to vaping, the tobacco industry owns a lot of those products, and actually they've done quite a bit of research in that area, and also similar products like heat not burn tobacco. And many of my colleagues would just reject all of that research outright and say there's absolutely no worth in it, and we shouldn't even read it or listen to it. Which I think is complicated because sometimes commercial actors do produce the first evidence of something to do with their product, and there may be a role for that. But I certainly support what the British medical journals have done in relation to tobacco industry funding in those publications, and I would expect that to happen more frequently.
I think that the tobacco industry seems to be the clearest example of this vested interest, but it appears to be more murky waters when we go almost further down the spectrum and think, what exactly defines a vested interest? Could it be, I don't know, I'm sure that if you look at Cambridge University's investments currently, they've certainly got links to the fossil fuel industry. They've probably got lots of links to the pharmaceutical industry. Does that count as a vested interest? Where do we almost draw the line?
Yeah, I mean, there's an active debate about pension funds, for example, and pension funds disinvesting from tobacco stocks, etc. In fact, there's been a big international campaign to get more employers to only offer, through their pension schemes, those cleaner sources of income. So what is a vested interest? Yeah, I think there's people who spend their whole lives studying this issue. So I think it is very, very complicated. But we also have to be pragmatic and recognize that, we live in free market economies, and it's very easy for there to be conflicts. But yeah, it's a live topic. And I think as much as possible, we have to protect public health from those vested interests because they are very successful. They have a lot of money at undermining our efforts. And to give you examples from alcohol, it took 5 years for alcohol minimum unit pricing to be introduced, while the Scotch Whisky Association fought the legislation tooth and nail through the courts, including to European level. And that is a specific industry tactic, is to delay, derail. And if they can't prevent regulation from coming in, they'll at least try and prevent it from happening quickly.
The legal system offers a good way of stalling certain interventions coming in.
Yeah.
And maybe even if it's based on precedents set decades ago, is perhaps full of certain loopholes that actually industry is very good at exploiting to prevent legislation coming in.
Yes, and the industry, again, it comes back to the resources that they have. These are big, large, powerful companies. Most of them are multinational companies. They have very deep pockets. So they're able to access the best legal advice and understand how the legal system works. So yes, I think court cases around all aspects of public health legislation are interesting. And this comes on to a point which I think you might have been thinking about asking me, which is the sort of parallels between the public health interventions that are happening now across the globe to address the pandemic and these health improvement interventions that I've talked about. And we're living in a period where there has been unprecedented interference in our lives as a result of the pandemic. Probably even more interference than in times of conflict, in terms of mass populations unable to leave their homes or access education, certain types of retail, prevented from traveling, borders closed in some countries, etc. This is public health intervention at scale by governments. Interference, actually, some people have called it, although I don't agree with that. So I guess the question is, what happens when we come out of this? Will governments think, okay, well, we could do this for COVID, so maybe actually banning junk food advertising online is not such a big deal after all. Perhaps we should just do it because there's enough evidence to suggest it's harmful, particularly to children. Whether there will be more intervention in other areas of public health, I'm a little bit skeptical, but it would be good if some of the evidence-based measures that we don't have in place now could be introduced.
A slightly cynical view that it's easy to slip certain bits of legislation through at times when the public attention is focused somewhere else. So a relaxation of restrictions that coincides with some other ones coming in could be seen as a net positive overall. On the other hand, we could actually see that, as we I think see around the UK, this growing sensation that people are not happy with restrictions currently imposed on their lives, and actually there's this sort of fatigue going on.
It's interesting. There's a bit of a debate about how much fatigue there is. There's fatigue in terms of everybody's just completely and utterly fed up with this situation. And, we can't see our colleagues, can't see our families and friends. It's just, there's been so many groups harmed by this. The unintentional or the non-direct harms of COVID, my own view, and I've been saying this from the beginning of the pandemic, will probably almost certainly outweigh the harms of the virus itself. Although, our hospitals would have been more overwhelmed, etc., if we hadn't taken action. But if you look at the data, going back to the data, so UCL has a COVID social study, which is done every few weeks. They publish reports every few weeks, and they've tracked compliance. They've tracked understanding of the guidance. I looked at it in different groups, and actually it has declined a bit since we came out of the stricter lockdown period in the summer, but it's still really high. Majority compliance is still over 90%. Complete compliance is probably around 40% now, but that's following every single rule to the letter. So there may be fatigue in some groups, but actually the British public, the UK public have complied surprisingly well with these huge changes to their lives.
Going back to the 4 Ps that you mentioned earlier, this kind of comes into support. That actually, if you can support people to make the decisions that you want to, whether it's supporting people who are having to isolate, whether it's supporting people by providing free PPE for wearing in certain places, or even just providing areas where people can socialise in a socially distanced way, is quite important in ensuring this kind of long-term success of a policy.
It's absolutely essential. And it's also essential that there's frequent communication with the public about these things, and that the public are continually thanked for the efforts that they're making. And there are differences across the UK in the success to which there has been good public health communication. In Scotland, our First Minister still does daily briefings. They've been going on for months. She's there every day. I think I've only seen one briefing that she didn't chair. And she reiterates the campaign, the facts campaign, which is our COVID campaign, at the end of every single briefing. She's always saying thank you. And irrespective of what you think of her politics, she's been a better communicator than we've seen at UK level, where the daily briefings were paused. They sometimes happen. Even I, following COVID forensically most days, don't always know when they're going to come on. It's quite frustrating. So I think, and then you can see, that from that game, the COVID social study, that trust in government is much higher in Scotland than it is in England. And it has been throughout the pandemic, and it's really declined very little. And I think that is actually not down to the fact that we've tackled COVID better than England, because actually if you look at the data, that's really not the case so much. It's more that it's about trust in government, and I think it's the communication that's caused those differences in figures around people's perceptions.
This kind of challenges the notion that actually we have public health competing with political interests on a massive scale, and the two are dramatically opposed to one another.
Yeah, they're not. I think you do see right-wing governments be far less willing to intervene, but they've had to intervene. Given that, sorry, I should use the right terminology. We have a Conservative Party in charge at UK level at the moment, who traditionally have been perhaps a little bit more reluctant to introduce public health legislation than, for example, the Labour Party, just looking historically. But they've had to address this public health crisis. So it will be interesting to see, as I say, when we emerge from this, what happens. Sometimes you get consensus topics. I mean, tobacco control has been a remarkable source of cross-party consensus, particularly in the last sort of 15, 20 years or so. In contrast to some of the other topics which are a bit more divisive, like sexual health, teenage pregnancy, drug misuse is a really good example. And then the interventions I've talked about around alcohol. So we'll see.
Why do you think, almost contrasting the dramatic response that we've had to COVID-19 to some of the rather kind of lackluster responses seen to other more slow-burning public health crises, why do you think there's been this difference, or rather, why do you think there's been rather slow action in tackling, for example, the obesity epidemic?
Well, actually, it's innate in human behaviour, part of this. So we've evolved to respond to immediate threat. I mean, that's what as humans, that's what we do. There's an immediate threat. The house is burning down, get out. And a virus is an immediate threat. You can't see it, but you can see the consequences of it very rapidly. Preventable mortality, hospitalization, etc. So because there is an immediate threat, the government acts, and it acts to protect its population, and also tends to follow other countries taking action. Although you can argue in the UK we're a wee bit slow to do that, but anyway, it's an immediate threat. In contrast, the health improvement public health topics that I work on, these commodities or products which are harmful to people's health, they contribute to chronic disease, which, as you rightly pointed out earlier, is not an immediate threat. It's a longer term progression of disease. It can take decades for somebody who's been drinking heavily to develop an alcohol-related condition. So I think that's probably behind it. That's one of the main reasons that governments are slow to act. And then the other thing is that the interventions that they need to invest in, let's use services, weight management services or smoking cessation services as an example. And the outcomes you would see from those don't happen quickly. The savings to the NHS only materialize, in most cases, not all cases, years in the future. And politicians are not elected to achieve change a decade from their election. They're elected to achieve change in their communities within their term of office. So those are some of the drivers, I think.
We can almost see the same effect on an individual level, where a single cigarette or a packet of cigarettes in a day isn't going to lead to a lung condition the next day, unless you're very unlucky.
It's completely the case. I mean, if you talk to young people, they don't have any sense of the longer term health harms of all of these behaviours, actually. So, we haven't evolved to think that way.
Do you think that, therefore, if government is not so suited, if the government in power for 5 years is not very suited to tackling public health issues, where do you think some degree of authority or control needs to be kind of concentrated in order to do that? And how can we protect that from these political interests that can go up and down in different cycles?
I think you need strong agencies. Policy is often made by groups, by networks, not by individuals. That's why we have lobbying and advocacy groups. So you need strong institutions and strong agencies. And actually, you're asking a very timely question, because, of course, one of the things we've seen in the middle of the COVID-19 crisis is the threat to Public Health England, the requirement for it to stop being Public Health England and become other things, with the creation of a National Institute for Health Protection, which is now in place, bringing together NHS Test and Trace and the health protection elements of Public Health England, So the infectious disease response functions. Meanwhile, the health improvement functions, the teams that I primarily work with, inequalities, justice, smoking, alcohol, tobacco, food, etc., they're not quite sure where they're going. They're employed until March, and they don't know, will there be a National Institute for Health Improvement, will there be another body, etc. So it's kind of ironic that in the middle of a public health crisis, you dismantle your state public health agency, which in many ways has been regarded as doing well in the topics that I work in for most of the time. So you need strong institutions to drive public health, not just politicians, but of course the reality is that it's the politicians that have the power over some of those institutions, as the example I just gave. So, yeah.
And we see another conflict here, which is that lots of the policies that we introduce, regardless of how positive the messaging is around it, there are a lot of seemingly punitive measures put in. There are fines, there are taxes based on alcohol minimum unit pricing, taxes on sugar, taxes on cigarettes as well, which can be quite unpopular in some cases. We have this conflict between almost people's short-term motivations and their long-term ones, which I think as humans we're very poor at managing. To what extent does the government have almost a right to, or does public health have a right to actually step in here and say, we're going to do something that's in the best interest of people in the long term, but not the short term?
I mean, that is part of the duty that governments have to protect the health of the public, a fundamental duty, and public health is part of that. And it does mean that when you introduce, particularly fiscal measures, actually making things more expensive. We talked about sugary drinks levy, alcohol minimum unit pricing, tobacco taxes. It might be that we have a levy or a tax on confectionery in the future, etc. We've made certain types of fossil fuels more expensive, as you know. So there's all kinds of fiscal policies that are applied. The argument has to be why are those being done? So, and in the topics I initially talked about, it is about reducing, all these topics, it's about reducing consumption, which will have benefits either for health or for the environment. So I think those interventions are justified, but government have to be able to provide a clear argument about why they're needed and what the health benefits will be. The other thing that they often come a cropper about is that they do get attacked for these things being regressive, as in these fiscal measures will harm people who have fewer resources more. So the poor will be hardest hit by these kinds of price measures. And to an extent that is true. I mean, absolutely is true. But there are clear deprivation gradients, for example, in relation to tobacco use and in relation to overweight and obesity and in relation to the harmful health consequences of alcohol, even if alcohol consumption is actually higher in more affluent groups. So again, it's about crafting an argument that yes, products will become more expensive, but in return we might be able to fund these services that will help these poorer communities, etc.
Is it a valid argument to say that actually we can justify more kind of restrictive measures for particular groups just by introducing minimum pricing, for example, because they're the groups who are most affected in some cases? And I know you had the example of almost the opposite example of alcohol, but we see quite a clear pattern with rates of smoking and socioeconomic status.
Yes, and that argument is used. And even with alcohol, as I say, although alcohol consumption is higher in groups that have more money, the harms of alcohol are actually most apparent in less affluent groups. So even with alcohol, that's a relevant example. So yes, you would say, well, fiscal measures are being applied. They may make things more expensive, particularly for poorer groups, but the poorer groups are the ones who are suffering the health harms. Therefore, a population level approach is proportionate. And that, again, if you look at how we've argued for many of these policies, these fiscal policies, those arguments have to be spelled out, even though they're quite complex to understand.
And I guess within this, you also have to prove that the changes that are being introduced actually work in reducing consumption, because otherwise you have actually quite a poor situation on your hands, where actually you've penalised some of the most vulnerable in society, potentially increasing financial stress even more for no change in behaviour, but just a bit more money for funding other services.
Yes, I think that's true. I do think that's true. But again, it's important to do that. So the resources that you get from these kinds of taxes, fiscal measures, do then support services that are needed. And they support services in multiple ways. They support services generally, be that health or education, but they may also support the support services like weight management, smoking cessation, alcohol treatment, drug treatment services. In the UK, we've actually been pretty poor at making that direct link, and the main reason for that is that we don't use hypothecated taxation here routinely. UK governments don't like saying, okay, for the sugary drinks levy, the money from that's going to sit in a pot that would then only be used for weight management services or health education in schools, etc. We haven't done that traditionally in the UK. In other countries, parts of the US, for example, you have had hypothecated programs where money from tobacco taxes has gone directly into funding health services and interventions, which are relevant for tobacco users. So that's a more direct link.
And why do you think that there's been a bit more resistance to that in the UK?
I'm not so sure, actually. This is probably a question for an economist. I don't know the history of why hypothecated taxation has not been popular here compared to other countries.
So I think one question to finish off here with, which is almost comes to the crux of what we're doing in public health, which is, can we solve this conflict between actually our personal freedoms and the reality that individuals' decisions actually have significant effects on those around them? So
that is, I think, in a nutshell, one of the fundamental challenges about working in public health and making the case for public health measures. And I think that, throughout this discussion, we've touched on multiple examples from COVID-19 to harmful commodity consumption, where the types of policies that I've been involved in helping to develop and to evaluate have inevitably meant constraining people's personal choices, constraining what they buy, how much they pay for it, and where they can use that product or consume it. And those policies all restrict those kinds of freedoms. And that's why you've seen such a big pushback on things like the smoking ban or alcohol minimum unit pricing, etc. And you're going to continue to see that. But the problem is, again, channeling the COVID-19 example, if you don't wear a face covering or you don't physically distance, you're putting other people at potentially immediate risk, particularly given that some people who have the virus are asymptomatic and they won't necessarily know that they're passing it on. We need to use more of those kinds of arguments in other areas of public health to say, well, if we don't reduce rates of overweight or obesity, or we don't prevent people from starting smoking or help people to quit, it means that we're going to have a more unhealthy society. It puts pressure on our health service and everybody pays for that. So actually, we can have a more vibrant economy. We can have more resources to go around for everyone if we have a healthier population. So that's a difficult argument to make, particularly for the kinds of long-term investments that I discussed earlier. But that is what population health, public health is about. It's not about individuals, it's about everybody or particular groups. And that means that a lot of the time we're really very unpopular, those of us in this field. But I really hope as we come out of a big public health crisis, I think it's pretty clear to me now that everybody in the country now realizes, how important public health is.
Even if it can be unpopular at times, public health authorities and individuals such as yourself in Britain are certainly very highly regarded, and for good reason, because these are questions that we certainly need to grapple with over the coming years and decades, and probably will never finish grappling with. But it's exciting to know that there are lots of ideas coming down the line and things that we could do to improve things. So that's probably all we've got time for today. So Professor Bauld, it's so kind of you to join me.
Thank you very much. Thank you for having me, and it was lovely meeting you and lovely speaking to you.
Thanks for listening to the Pager podcast. If you've enjoyed it, do leave us a review, share it with a friend, and come back to listen to our other episodes. As ever, we'd love to hear what you think. You can reach us at Pager Podcast on Instagram and Twitter, or email us at pagerpodcast@gmail.com. Bye for now.